Okay, so now let us start with a new topic, that is cleft lip and palate. So cleft lip and palate, first we'll start about with the cleft lip. Cleft lip, it is more commonly seen in males. Left side is more affected, ratio 2:1. How does it happens? Cleft lip, when there is the fusion of the failure of the fusion of the median nasal process, and with the maxillary process. Okay, once again, it is the failure of the fusion of the median nasal process with the maxillary process. It can be unilateral cleft or it can be bilateral cleft. Associated syndromes, Tau syndrome, or also known as trisomy 13, Stickler syndrome, Perry-Robin syndrome, or Treacher-Collins syndrome. About these syndromes we'll discuss in the later part of this video. So now coming on to the clinical features seen with cleft lip. Broad nasal flaring, you will see that there will be broad nasal flaring, poor oral feeding, malnourished, tipped columella, loss of general anatomy. Columella is this part of the this is the nose. Okay, my nose is too bad. Suppose this is the nose, so this part is the columella. Okay, so columella, because here it is a cleft, so there will be a tipped columella. Loss of general anatomy. Etiology can be due to increased parental age, family history, teratogens or phenytoins, smoking, pregnancy, and consanguineous marriage, that is marriage among the cousins or relatives. Okay, so next is the cleft palate. Cleft palate, this is my primary palate. What happens? The failure of the fusion of the both maxillary shelves, that is the palatine shelves, cannot fuse, and also there is a downward growth of this intermaxillary process grows downward. Etiology of cleft palate: failure of the tongue to drop down, non-fusion shelves, alteration in the intrinsic forces, failure of the mesodermal migration, rupture of the cyst which is formed at the site of fusion, non-fusion of the shelves, failure of the tongue to drop down, alteration in the intrinsic forces, failure of the mesodermal migration, rupture of the cyst which is formed at the site of fusion. This is the etiology of cleft palate. Etiology of cleft lip was both, can say, increased parental age, family history, teratogen, smoking, consanguineous marriage. Cleft palate ka, if you are asking, then it be the failure of the tongue to drop down, non-fusion of the shells, alteration in the intrinsic forces, failure of the mesodermal migration, rupture of the cyst which is formed at the site of fusion. Incidence: first most congenital anomaly is the cleft foot. Second is the cleft lip and the palate. According to WHO, every 2 minutes 1:600 worldwide cleft lip and palate patients are seen. Cleft lip was more common in males, cleft palate is more common in females. Okay, development of phase occurs at the 4th week of intrauterine life, and cleft is seen in the 8th week. Now coming on to the classification. The first classification is the complete or the incomplete classification. The second classification is the VOWS classification, which is class 1, class 2, class 3, class 4. Class 1 soft palate, class 2 soft palate and hard palate. Class 3 is unilateral, class 4 is bilateral. In unilateral, you will cover the lip, the primary palate, the hard palate, the soft palate and the alveolus. Again, classification: soft palate, hard palate, unilateral, bilateral. Unilateral, what does it? Complete cleft includes the cleft of the lip, the cleft of the primary palate, cleft of the hard palate, cleft of the soft palate and the alveolus. Now the Carnahan-Stark classification, or also known as tuning fork classification, right and left side, how does they have done? They have made it into 9 segments. How they have numbered it? 1, 2, 3, 4, 5, 6, 7, 8, 9. This part is the incisive foramen. The 1 and the 4 represents the lip. The 2 and the 5 represents the alveolus. The 3 and the 6 represents the palate which is anterior to incisive foramen. The 7 is the anterior hard palate. The 8th is the posterior hard palate, and 9th is the soft palate. Now one more modification was given, in which they have included the nasal floor. They haven't numbered it. Same nasal fold, nasal floor, 1 and 4 lip, 2 and 5 alveolus, 3 and 6 prime palate, which is anterior to incisive foramen, anterior hard palate, posterior hard palate, and soft palate. Now, how will we do the diagnosis? For the diagnosis, prenatal ultrasound or color Doppler ultrasonography is done for the diagnosis of the cleft lip and palate. Now, what are the associated difficulties or challenges? First of all, feeding difficulty. So, draining of the fluid in the nasal cavity. Infant needs to be held at 30 to 40 degree angle to aid in swallowing. They should be held in an angle that is 30 to 45 degrees so that it will aid in the swallowing. How do we feed them? Bottle feeding, tube feeding, spoon feeding, etc. Feeding problems. Dental problems includes the hypodontia, means decrease in the number of teeth, crossbites, supernumerary teeth, etc. Skeletal, maxillary hypogrowth, that is maxilla will be deficient. Nasal tip deviation to the normal side. Okay. Prognathic mandible, that is class 3 tendency. Concave profile. Facial disfigurements. Ear or the middle or the disease, middle ear disease. Nasal twang, that is they will have some kind of nasal voice when they talk. Speech defects due to vulvopharyngeal insufficiencies. Speech defects due to vulvopharyngeal insufficiencies. Once again, what are the associated syndromes with cleft lip and palate? Feeding difficulties, that is draining of the fluid in the nasal cavity. Infant need to be held at an angle of 30 to 45 degree to aid in swallowing. Next is the dental problems. Swallowing is done with the bottle, tube, or the spoon feeding. Dental, hypodontia, crossbite, supernumerary teeth. Skeletal, maxillary hypogrowth, nasal tip deviation to normal side, prognathic mandible, concave profile, facial disfigurements, middle ear diseases, nasal twang, speech defect due to vulvopharyngeal insufficiency. So now how do we manage it? A multidisciplinary team approach is important for the management of cleft lip and palate. So here I have divided them according to the age and the management criteria to be done on the age basis. So at birth, initial assessment or pre-surgical assessment is to be done, that is feeding oroantral fistulas. Pre-surgical assessment will be done for feeding oroantral fistulas. Appliances, partial obturator which aids in surgical and feeding. We will discuss about the nasoalveolar molding in the next video, okay, because it has to be discussed in detail. So at birth, initial assessment, pre-surgical assessment for feeding oroantral fistulas. Then at 3 to 6 months, primary lip repair in which Millard's rule of 10 should be followed. That is 10 gram of hemoglobin, 10 pounds weight, 10 weeks of the baby, and 10,000 WBCs should be present. Then 9 to 18 month palate repair should be done because speech begins at the age of 2 years. So at 2 years, speech assessment should be done. At 3 to 5 years, lip revision surgery. Remember, 3 to 6 months lip repair surgery, 3 to 5 years lip revision surgery. Then 8 to 9 years initial orthodontic intervention should be done and preparation for the bone grafting, alveolar bone graft. Then at 9 to 11 years, alveolar bone graft. Why? Because assisting the canine eruption. Then at 12 to 14 years, definitive orthodontic treatment is required. 16 years, nasal revision surgery. 16 years, nasal revision surgery. 17 to 20 years, orthognathic surgery. Once again, we'll discuss the management. At birth, what we are doing? Number 1, at birth, initial assessment or pre-surgical assessment. 3 to 6 months, primary lip repair, Millard's rule of 10. 10 gram hemoglobin, 10 pounds weight, 10 weeks, 10,000 WBC. 19 to 18 months, palate repair. Speech develops at 2 years. At 2 years, speech assessment. 3 to 5 years, lip revision. 8 to 9 years, initial orthodontic intervention, preparation for alveolar bone graft. 9 to 11, alveolar bone graft because canine will erupt, assisting the canine eruption. 12 to 14 years, definitive orthodontic. 16 years, nasal revision surgery. 17 to 20 years, orthognathic surgery. Okay. So as we have discussed in the beginning that there are certain syndromes which are associated with cleft lip and palate. Those were the Perry-Robin syndrome. Perry-Robin syndrome, it is the triad of 3 important disorders, that is the presence of micrognathia, that is small jaw, glossoptosis, that is tongue is attached backward, and cleft palate. Micrognathia, glossoptosis, cleft palate. Treacher-Collins syndrome or mandibulofacial dysostosis, underdeveloped both side of the face, that is bird-like or fish-like face. Anti-Mongolian slant, this is what anti-Mongolian slant you can see in the eyebrows, and presence of a columbo of the eye, that is opaqueness in the eye is present. Columbo, and remember what are there in mandibulofacial dysostosis, bird-like face, anti-Mongolian slant of the eyebrows, and columbo in the eye, that is opaqueness in the eye. Then the third one is the Patau syndrome or the trisomy 13 condition with extra chromosome 13, in which you will see clenched hands, closed set of eyes, decreased muscle tone, low set of ears, mental retardation, small eyes, head and lower jaw. Okay, again, clenched hands, closed set of eyes, decreased muscle tone, low set of ears, mental retardation, and small eyes, head and lower jaw. Last one is the Stickler syndrome. It is a genetic disorder. It has midfacial hypoplasia. It has got hearing loss, cataract is present, glaucoma and high myopia. So this was all about the cleft lip and palate. The nasoalveolar molding we'll be discussing in the next video. Again, once we'll just do a quick revision. Cleft lip common in males, left side is more commonly affected, 2:1 is the ratio. Failure of the fusion of median nasal process with the maxillary process can be unilateral, bilateral. Associated syndrome, Tau syndrome or trisomy 13, Stickler syndrome, Perry-Robin, Treacher-Collins. Cleft lip has got broad nasal flaring, poor oral feeding, malnourished, tipped columella feeding problem, so it will cause malnourishment. Tipped columella, loss of general anatomy. Etiology, increased parental age, family history, teratogens, phenytoins, smoking, pregnancy, consanguineous marriage. Now next is the cleft palate. Failure of the fusion of the maxillary shells, downward growth of the intermaxillary process, failure of the tongue to drop down, altered intrinsic forces, non-fusion of the shells, failure of the mesodermal migration, rupture of the cyst which is formed at the site of fusion. Incidence, first common congenital defect is the cleft foot, then the cleft lip and palate. Every 2 minutes 1:600 cleft lip and palate patient is born according to WHO. More common cleft palate, more common in females. Development of face at 4th week and development of cleft lip and palate at 8th week. Classification, complete in and incomplete. Vowels classification, soft palate, soft and hard, complete unilateral, complete bilateral. Carnahan or the tuning fork classification. Diagnosis by prenatal ultrasound or color Doppler ultrasonography. Problem, feeding problem, dental problem, skeletal problems. Okay. This management at birth 3 to 6 months, 9 to 18 months, 2 years, 3 to 5 years, 8 to 9, 9 to 11, 12 to 14, 16 and 17 to 20 years. Syndromes, Perry-Robin syndrome, Treacher-Collins syndrome, Patau syndrome or trisomy 13 and Stickler syndrome. So this is about the cleft lip and palate. Now next nasoalveolar molding will be updated in the next video. If any doubt, please write in the comment section. I will be happy to help you. Thank you.